Now I am going to just give a quick introduction for our speaker. I went to George Mason with Saskia, which is how I met her. We both have PhDs in biodefense from George Mason, so I got to see all of the great work that she was doing while we were in school together. And she is an infection prevention epidemiologist, and her research focuses on infection prevention as a health security measure and works to explain the poor utilization of infection prevention and control within the US through political economy. She works to ensure hospitals are prepared against biological threats from drug-resistant infections to influenza and special pathogens like Ebola virus disease. She has an MPH in infectious disease epidemiology, an MA in international security studies, and she's certified in infection control. She is also my Smithsonian Outbreak exhibit buddy. We got to go up there and check out their exhibit on emerging infectious diseases, and we had a great time. So if you are in the DC area and want to check it out, I would highly recommend it. But at this point, I am going to turn it over to Saskia. Thank you so much for joining us tonight, and we look forward to hearing your presentation.
Thanks so much, Jen. I really appreciate it. And this is definitely one of the more fun topics I get to ever discuss. So I'm excited to go over some biopreparedness and healthcare with everybody, because I think sometimes when we discuss biodefense and public health preparedness, we kind of assume hospitals have it together. And heads up, we don't. It's a pretty critical infrastructure that tends to be ignored when it comes to biopreparedness. So I'm going to go over with everybody just kind of where we currently are in healthcare, some of the bio threats that we face. And I actually just did a presentation to the Association for Infection Preventionists, and very few people understood the accidental bio threats that I'm going to discuss with you today, and how it really truly hits healthcare and we're not talking about it. And then I'll discuss with you a little bit of the hospital outbreaks and exposures and kind of where we're at with this, what we're doing, and future directions. So healthcare as a critical infrastructure. This is really scary to me. So we have in the United States over 6,210 US hospitals. And I bring this up because I think it's pretty startling, if you will, to think about how many hospitals we have in the US in terms of not just federal government ones. We have community and critical access hospitals are becoming more common. For anybody who's driven across the US or in a rural area, critical access hospitals are those that try to really fit that need for areas that may not have close access to a hospital. Is literally what it sounds like, a critical access hospital, because that's the only place you could seek care or unfortunately like die. So hospitals in the US are not just prolific, but it's actually the #1 industry. So this is a huge source also for really just healthcare employees and building out the workforce. So across the US, we have almost 1 million staffed beds, and every single year in US hospital admissions, we have 36 million. And this is a very, very big booming economy. So when we talk about healthcare preparedness, I think it's really important to acknowledge how many hospitals we have to prepare, and realistically the financial implications of hospitals not getting business or people not going to them. You know, we'll talk about Ebola in a little bit, but if you think about the fact that if we just are looking at US community hospitals, so that's 5,262, those are the ones that we really focused on for Ebola preparedness in 2014. So that's a lot of hospitals, and trying to maintain a level of readiness is extremely consuming in terms of just staffing, resources, and finances. So if we have people not going to those over 5,000 hospitals or trying to avoid them because they're scared they're going to get Ebola for whatever, ridiculous fear that was being spread at the time, that's going to hit the US economy very, very hard. So when we talk about healthcare preparedness, this is not a new concept, but biopreparedness is very new when it comes to US hospitals, which is kind of scary to me. So this really started to come up after Ebola in 2014, because, we had flu season and other countries had dealt with like SARS and MERS, but we really in the US haven't experienced anything like that. So, in terms of the role of hospitals, I like this because we focus on laboratories and the role of hospitals in public health. And the truth is that whether it's EMS, the physicians, your labs, all of these centers, healthcare plays a really big, intricate role because we are the front lines. So hospitals are not only the ones that identify potentially infectious patients, we test for them, we treat illness, but we have a really big role in surveillance. Sometimes when I've spoken to people about what disease surveillance look like, they think, oh, public health department, CDC. But the truth is, where are you getting that? So for me, I do communicable disease reporting across our healthcare system. So that means if a patient comes in and tests positive for, a number of, I think it's there's a list of 30 or 40 communicable diseases that we're required by law to report to public health. That's my job. I am required to do that. That gets fed into county, which gets fed into state public health, which then feeds it to the CDC. So we, from a public health surveillance preparedness standpoint, are really dependent upon hospitals doing their reporting for communicable diseases and doing it timely and correctly. Sometimes they rely on just the labs to do it. Sometimes we rely on medical providers to do it, but there's a lot of room for error because if you think about it like this, if you have a hospital that has their infection preventionists like myself doing your communicable disease reporting, and maybe that person's on vacation and nothing's getting reported, that could be a really big way to miss an outbreak that's going on, or maybe a case of anthrax, things like that. So this is the prime place for disease surveillance, but also preventing something from spreading. When I have a patient that comes in with MERS, if I don't isolate them appropriately, we're going to have a big outbreak on our hands. And you'll see why in a little bit. So I wanted to review the spectrum of biothreats before we get into some examples of hospitals kind of acting as amplifiers, if you will. There's a lot of terms I'm sure you've heard in this class, among others, for biological threats, whether it's health security issue, biodefense, biopreparedness. We like sticking bio onto just about everything, and there's a lot of topics that fall under that umbrella, and all of these end up trickling into healthcare. We have bioterrorism, whether it's state or non-state, pandemics, antimicrobial resistance, which I'll always put here as AMR. I'm sorry, in healthcare, we love our acronyms. Vaccines are a huge issue. How are we going to distribute these? Hospitals really have to plan in advance because we have to ensure our staff are vaccinated as well as our patients, or at least offer it to them. Biosurveillance, biodefense, and then biotech, CRISPR, Cas9, that kind of gene editing technology that you're increasingly seeing in the news. I think there was just a Netflix documentary that came out about it. But realistically, people, scientists, and what we call garage biohackers kind of doing some genome editing to really kind of test the waters to see what we can change. So global health security is a really big aspect of this, and it's becoming more of a focus in healthcare, and healthcare is becoming more of a focus in global health security. I will talk about it in a little bit, but really what we used to see is when we'd have those conversations about global health security, they might mention hospitals in terms of critical infrastructure, but no one would ever discuss things like infection control, which when you hear about infection control, that should be your indicator in terms of how prepared is this hospital to handle infectious diseases. Because the truth is that for most hospitals, it is your infection prevention team, like myself, who are responsible for doing any kind of education, training, and response for infectious diseases. And that's simply because we have the knowledge skills to do that. Emergency preparedness departments deal with everything else, but they don't necessarily they're not necessarily the subject matter experts when it comes to infectious diseases. So, when we're discussing that whole an outbreak anywhere is an outbreak everywhere, technically that's true. Some countries are more vulnerable than others, but more and more now we have more threats that in fact impact infection prevention and control, or IPC. And this is really because now that we are recognizing hospitals as a vulnerable point for infectious diseases, mostly because we haven't been paying attention to them for biopreparedness, but also because we're finding that realistically hospitals are really good at spreading diseases. I know that's not something people like to hear, but we are really, really good at it. And that's because you're dealing with hundreds of patients a day, hundreds of healthcare workers, visitors, and human error. People make mistakes. So now, 50 years ago, we really didn't have to worry about in healthcare an emergent infectious disease like Ebola, but 2014 really changed all of that. So biothreats are especially unique because they're really difficult to tackle in terms of, unlike nuclear or chemical, they don't proliferate, they have incubation periods, and this really changes the dynamics of healthcare and infrastructure. So one end of that spectrum are natural biological threats. So we have these natural outbreaks: SARS, coronavirus, Ebola, Zika, these things. They're especially unpredictable. They really are challenging because not only are emergent infectious diseases increasingly becoming an issue, but we're seeing that 70% of them are zoonotic, which means they have an animal origin or component to them. So as I've really emphasized with healthcare workers, and we're starting to really try and incorporate more into training, is asking patients, do you work with livestock? I mean, you might think that's a pretty simple question, but if a patient is a farmer or works in a poultry facility or works in a pet shop, that is a relevant piece to infectious disease response. Antimicrobial resistance is another piece. And I always struggle if this should be under the man-made biothreat, because technically it is. We are the reason that antimicrobial resistance exists, but we'll go with natural for now. Medical tourism is actually a really big issue we're starting to see. So, when we talk about the next outbreak is just a flight away, an airplane ride away. Yeah, that's true. In terms of, we're thinking about Ebola, we're thinking about those crazy viral hemorrhagic fevers, but we also really worry about this with extremely resistant microorganisms, because what we're starting to see more and more is, a patient is getting treatment here, decides to travel abroad to get treatment that might be cheaper, and that country doesn't have the kind of antimicrobial or diagnostic stewardship. They come back and we accidentally stumble upon a highly resistant infection, and that is so scary because we don't have the surveillance mechanisms in place. So for natural biothreats, we also have an R0 that changes constantly. For Ebola, it went from 1 to 2.5 in the 2014 event. And unfortunately, response mechanisms, as I'm sure we all know, are lacking on a really good day. Infection control and public health are constantly underutilized and underfunded. And I think this is always the name of the game when it comes to prevention. Infection control and healthcare, we're kind of seen as that necessary evil, that cost center, not a revenue generator. So I want you to keep that in the back of your minds when we talk about the role of hospitals in biopreparedness, but also as a vulnerability for public health preparedness. So this was just, I'm sure everybody has seen this map before. I just really like it because it also included some of these highly resistant infections we see. Enterovirus D68 is definitely becoming a problem, but CRE, MRSA, those resistant infections are also highly creeping up. We're starting to see some totally resistant infections that are picking up genes along the way. So should they show skills in transmission between humans, very, very concerning. So antimicrobial resistance, we always like to call it AMR. I won't spend too much time on this because realistically, I think I beat this to death enough, but every single year in the US, we have 2 million cases. These are only the ones that are reported. If I'm being totally honest with you, it is probably 4 or 5 times higher than that. We see 23,000 deaths a year. Again, those are what's reported. And we know that AMR is probably one of those more difficult challenges to tackle. Really, how do you combat something that deals with both medicine and agriculture and food, and then also infection control? So what we know is truly this is a growing problem we are struggling to combat because we don't have a good understanding of it. And we're just trying to get an understanding of the surveillance dynamics for AMR because we only test for certain resistant infections. Medical tourism, as I mentioned, is a huge risk. And now we're starting to see these more highly resistant genes and infections that are becoming more prolific in healthcare, meaning that it wasn't just one single case we identified. It's, okay, we've had a patient every other week with this. We need to be really good at isolating them. So next would be the intentional biothreat. And these are, ones that people may not realize in healthcare we have to worry about, but if you asked an emergency preparedness person in the hospital, they will always put bioterrorism on the top list in their hazards vulnerability assessment, which always kind of cracks me up because I'm more worried about pandemic flu. But these are realistic issues that if we had a group of patients that came in and had, some crazy infection, right away, we may not realize it's a bioterrorism attack. And so I point to the non-state actors, anthrax definitely is going to get a red flag. But something like the salmonella attack that happened in 1984, we didn't actually know that this was an intentional act until somebody came forward and said something. So for me, I have reported one time like 12 cases of a Shiga toxin producing E. coli. And that's just an outbreak in my eyes. That's a group of people that, in fact, it was a team that went to a restaurant, they all got sick, those kinds of things. So that's not gonna have a red flag as a bioterrorism attack, but having that awareness in healthcare to ask those questions is really important, and communicate that with public health, because if I'm not communicating well with local and state, or my infectious disease physicians aren't, we're leaving ourselves very vulnerable, and them vulnerable to not picking up on these breadcrumbs. You also have these state-sponsored programs, and Jen and I probably have gone through these ad nauseum in our education, but these are really fascinating just in terms of the difficulty it actually is in building a biological weapon. So we won't go too much into that, but that is somewhere on the biological threat that spectrum we realistically need to consider, because in the event of a terrorist attack that we know is a terrorist attack, hospitals are going to have an influx of people, both the worried well and the sick. So how do we handle that? Do we isolate people? Do we go into diversion, which means that we don't accept any new patients? We have to have a strategy for this, but that also has to include decon, for something like anthrax, where we're concerned about the spores being spread throughout the hospital, because anthrax is both frustrating and easier. It's frustrating in terms of a decon standpoint, but for an infection control aspect, if I have one patient with anthrax, as long as I'm not worried about their clothing, I'm not concerned, because the truth is they can't spread it. Anthrax is not transmissible between people. I don't have to worry about them coughing and getting the person in the next room sick. So all of these weird nuances have to be considered when it comes to hospitals preparing for infectious disease threats, whether they're intentional or natural. Next would be the biothreats, bioerror, not bioterror. And so this one I think is really fascinating. I got to speak to it a little bit to infection preventionists, and it was so interesting that we don't ever consider this in healthcare. But as more and more research is being done on organisms, both to change their functionality, but also see, what we can do with them, we have to consider that we might have lab personnel that get sick, or there's a biosafety failure. So biosafety is when we protect people from the germs. We saw failures of this at the National Institute of Health when they found smallpox in the freezer, or the Department of Defense mailed anthrax that was not properly killed, if you will. And biosecurity then is when we worry about protecting the germs from people. So that's really what we saw with the Amerithrax attacks in terms of theft of an organism, or people stealing it for nefarious purposes. And the next is the two different research topics we think about. Dual use research of concern, or DURC, is basically life science research that could potentially be misused for bad purposes. And I'll give you an example in a little bit, but gain of function then would be genetic manipulation of a pathogen. That's exactly what it sounds like. We're giving it a new function. So, when we talk about the biorisk spectrum, I think it's really easy to just see natural versus deliberate, like an attack, but there is a whole group in the middle, that laboratory accident, that lack of awareness. And for anybody who has kind of watched that Netflix documentary, I cannot remember the name, I'm sorry, or had an understanding, or kind of just kept in the news about the biohackers, the garage do-it-yourself biohackers. A lot of these people are editing different pathogens like salmonella, or they're just kind of messing around with some genes, and they will inject themselves with it to see if it if it gives them the desired effect. And so that's actually really concerning from a healthcare perspective, because if I have a patient that comes in that is admitting to self-injecting some edited genomes, I don't really know how I'm going to respond to that, but that's something we do need to consider that has never been on our radar before. So that's really that laboratory intentional accident, if you will, but also, what happens when we have somebody who really is deeply concerned, or a lab accident. Oh, a natural selection. Yeah, so it's, sorry about that. What happens when we have a lab worker that is, accidentally spills something? Everybody's seen Resident Evil, but, there was just that incident where somebody poked themselves and they were doing smallpox work. I mean, I think of all the things that I see in our lab, in our micro lab, and just our tiny hospitals in the grand scheme of things. And those are just teeming with failures to occur. So if I just have one of them accidentally poke themselves or infect themselves, then that's something from an infection control standpoint I need to consider, because do I isolate that person? Do I prevent them from coming back to work? Things like that. So next is food safety. And I mentioned this before, but in terms of like asking people, hey, do you work with agriculture? Are you a farmer? What kind of work do you do? Because that is going to guide diagnostics, but also, believe it or not, communication becomes a really big gap in healthcare. And I bring in prions and CJD because here's a really good example of how failures occur in healthcare. I have seen repeatedly medical providers be concerned about CJD in patients, prion disease, and order a test. Well, the tricky part about prion diseases is that any lab equipment you use on it has to be disposed of. We can't just put it in an autoclave. It doesn't kill it. So the problem, though, is they order the test. Nobody tells the lab or anybody receiving the samples what it's being used for, just that it needs to be prepared for send out. So all of a sudden we have lab workers that were exposed, or we have equipment that's been run, and these are the little weird nuances of healthcare. So when we have these huge gaps in communication that occur, even about something as, hey, I'm testing this patient for CJD, for a prion disorder, you would think something like that should be totally fixed, totally good to go, but it is not. So as we talk about outbreaks, think about those gaps in communication, because they really exist and they are very, very frightening. So next, I'm going to go into some examples of hospital outbreaks and exposures, because I think this is really telling for how hospitals function as both critical infrastructures, but also why we are a huge vulnerability that I wish people would pay attention to. So the first is Ebola, our favorite, the big hot topic that a lot of people get into. So in 2014, in late September, we had a patient who was traveling from Liberia, came into Texas Health Dallas Presbyterian Hospital, which has now been renamed for branding purposes, not surprisingly. And interestingly enough, not enough people talk about this, he actually went to the emergency department the first time, was sent home thinking, oh, you just have like a sinus infection and some traveler's diarrhea. Came back the second time because they really had concerns actually about Ebola given his travel history. So to me, this is really interesting because this is 100% what would happen in most hospitals across the US. If any of you have been to an emergency department, you know how they work, you know how busy they are, and how likely you are to just get sent home if you arrive with like traveler's diarrhea. So I think what's quite interesting though is that we had no secondary cases of Ebola in the emergency department related to that. When we had the two nosocomial or healthcare associated cases of Ebola, it was in the two nurses who took care of him in the intensive care unit or the ICU. They have not determined how exactly that transmission happened. We never will, but there were so many gaps in infection prevention and response to this that there were probably dozens of them. So ultimately, we found out a lot about this situation, not just because it would have happened anywhere, but because one of the nurses chose to sue the hospital after she recovered from Ebola, while Thomas Duncan did not. Both nurses did. So we found out some interesting things in this, and that was, first and foremost, this was an entirely novel situation. Actually, I'm going to go back for a second. And the hospital really didn't handle it well. You had a nurse who was saying, hey, I don't know what to wear into this patient's room. So what do? They asked for more personal protective equipment, or PPE. Administration denied it. Invasion of privacy. Basically, this was a situation where you had healthcare providers saying, I don't feel comfortable going into this room with just a gown, gloves, and a mask. What else do I need to be wearing? And then managers and supervisors going online, printing out what they had and just handing it to them. This was not well handled, but I am not surprised by it. Because what happened really in the situation is that we had no hospital in the US that had ever experienced Ebola. We're just not trained for it. Why would we ever assume that we would get a viral hemorrhagic fever in the US? We don't have outbreaks. They occur very sparingly in countries that they tend to occur in, like Africa and West Africa specifically. So across the board, I can safely say, outside of like Emory and maybe Nebraska, no hospitals in the US that, 6,000 amount had ever thought to themselves, you know what I should do? I should probably start focusing on viral hemorrhagic fevers and emerging infectious diseases. That's just not what they do, because hospitals are focusing on what's in front of them and not wanting to spend extra money on a disease they will likely never see. So you had this entire US healthcare system brought to its knees because of a single unexpected case. We had brought patients with Ebola into the country. Most of them were healthcare workers, but we knew what we were getting into. This was a prime example of a patient walking into the emergency department and everything just kind of crumbling around them. This is not surprising for anybody who works in healthcare. We were all kind of like, yeah, no, that's gonna happen everywhere. And this is just because, guess what? We don't think about it, but also we're really crummy at infection prevention. We're really crummy at hand hygiene, isolating, and getting people to rapidly put on their PPE. So in this case, because Ebola has very specific PPE, I'm sure a lot of you remember how, those massive space suits and everything. It's very cumbersome, it's very time consuming, and no one had competencies. We had never done it before. So now all of a sudden you have hospitals racing to get the PPE and training their staff on these very complex systems and getting the flow down. But on top of it, guidance was changing constantly. I remember making algorithms for this at the time, and I was working in a pediatric facility. Every single week we were having to change them because the CDC was changing what the isolation precautions were. Originally, if you actually went back and looked at their guidance for isolation precautions for infectious diseases, Ebola was contact droplet, which means mask, gown, and gloves. Now they threw in airborne because they were concerned that basically with the advanced medical setting of the United States and doing aerosol generating procedures, we were going to aerosolize this disease, which totally makes sense because this is a prime example of a disease because we don't see it ever really, and it's very, very uncommon. All of the guidance that existed was around treating it in an African country that had limited resources in terms of healthcare. But if you take a disease like that we don't see in the US, and you bring it to any hospital where we have so much technology, so many intervention methods, all of a sudden you have just created a million different ways to transmit this disease. Dialysis, ventilation, C-sections, all of these things that you might not see, on the front lines of an Ebola outbreak were things that we suddenly had to consider. Oh my gosh, what do we do with the dialysis machine? This actually happened in Dallas. They tried to put Thomas Duncan on dialysis, and then after he died, they didn't know actually how to totally clean out the machine because there was no competencies, no manufacturer recommendations for how to clean it with something like Ebola. So they had to throw away this like $100,000 piece of equipment. So all of these things were tested. How do we dispose of waste all of a sudden? Hospitals are having to prepare for disposing of BSL level 4 waste. And for Emory, they were also threatened with waste disposal in terms of their city was saying, we will cut you off plumbing wise and waste management if you don't figure out a way to properly disinfect human waste, meaning that they suddenly had to create a protocol for pouring bleach in the toilet before a patient could flush the toilet, things like that. So these are all the crazy rabbit holes we had to go down during Ebola that in a million years nobody ever anticipated, because we thought, all right, if a patient with Ebola comes into the US at this point, either we're going to know about it or we're going to call the CDC, they're going to swoop in, save the day. This is a very, very particular nuance of healthcare. CDC cannot come into a hospital and take over unless we give them permission and even ask them. So in this situation, CDC came in and offered support, but Dallas had to kind of lead the way. And it was a very interesting situation because remember, hospitals, you know, out of those 6,000 hospitals, a majority, you know, over 5,000 of them are private hospitals. They're not government owned. They have their businesses basically. So it's a very weird gray line that you have to kind of straddle for managing infectious disease response, especially even preparedness in this situation, because the CDC can't just come in, grab the patient and leave. There has to be an entire process for that. So Ebola was, I think, a very big learning moment for the US healthcare system, and especially in terms of understanding the role of infection prevention and control. IPC is frequently seen as just hand hygiene and trying to avoid getting MRSA, right? This was a good example of, okay, our emergency preparedness programs and hospitals do not have the skill set or knowledge set to handle something like Ebola or to do education and training. So studies have shown that an overwhelmingly large percentage of Ebola preparedness in US hospitals during this time period were run by infection prevention and control programs, to the point that it took up 80% of their time. So this means that as we start to really recognize that emergent infectious diseases are a huge concern and we're very vulnerable in the US, we're very dependent upon infection control programs and acknowledging that ultimately they play a big role, but we're not really incorporating them into biodefense plans. So we do have this current outbreak in the DRC, and 18% of those cases are nosocomial, which means healthcare associated, meaning that a person came in and got Ebola because of either a healthcare exposure to, you know, they were a healthcare worker or they were just being seen and got it by, you know, cross-contamination. So next is SARS-CoV. Now this is a lot, so I really just want to focus on a couple interesting things. SARS coronavirus is really fascinating. We haven't seen any cases since 2003, but what made this really fascinating is that SARS and MERS, both of these coronaviruses, have shown us how high a propensity hospitals have for transmitting novel infectious diseases. So we had a patient that came back from Hong Kong, returned to Toronto. She ended up dying with the disease, but her son, who she gave it to at home, goes into the hospital and he becomes this index case, this patient zero, if you will. So, you know, without going too far down the rabbit hole, basically what Toronto had to do was declare a provincial emergency and hospitals went into diversion, which means that non-emergent cases, you know, we turn away ambulances basically, unless it's an emergent case and that patient's going to die. So they also used enhanced infection prevention practices, visitor limitations, enhanced or additional personal protective equipment like an N95 mask, full gown and gloves, social distancing, those things. That was the first phase of the outbreak. So after that started to drop off and they thought, oh, we're done, we don't need to use this anymore, they dropped the enhanced infection prevention practices. And one thing I will tell you is that, you know, healthcare workers, they don't like having to wear PPE. It's a lot of work. It's exhausting. It's very daunting. So if you tell them, oh, you don't need to wear all of that, you know, but still be mindful there are infectious diseases out there, I can almost guarantee you a lot of the time, they're just going to be like, oh, I'm so exhausted from this, I'm not going to use it at all. That's what happened. So by saying you don't need to use enhanced precautions, but you still need to be mindful of infectious diseases out there, they had a massive drop in infection prevention practices, and lo and behold, phase 2. So now we have the secondary phase of the outbreak because we stopped using any infection prevention practices, no isolation, poor PPE compliance, poor hand hygiene, things like that. So despite the fact that Toronto actually ordered a quarantine, they found that dropping infection prevention, or, you know, realistically was the issue that caused the second phase, and that when we used enhanced precautions, That's what actually halted the outbreak. In the second phase of this outbreak, if you see this, almost 100% of the cases were related to exposures to a single patient in a hospital. So that's the crazy part, is when we focus on quarantine and social distancing, and those are definitely important factors, but hospitals are so good at acting as amplifiers for diseases, especially during outbreaks, that if we don't pay attention to the basics of infection control there, we're really creating a ripe situation for an epidemic, a pandemic. So next would be MERS, and MERS we're still seeing cases of. Saudi Arabia tends to get the brunt of it, but what's really interesting in regarding MERS is that the cases we see, yes, there is some relation to camel exposure, but more and more, there's a pretty consistent theme with healthcare transmission. And we see this due to delays in isolation, poor separation of suspected cases. I'm going to sound like a broken record because it's the same thing over and over again. Inconsistent adherence to isolation precautions, not using the PPE you need to, busy emergency departments, just constant visitor movement and traffic. But what I think is really fascinating about MERS as a healthcare issue and as an example is that in 2015, there was an outbreak in South Korea. Depending on the research that's out there, between 91 and 99% of cases were related to exposure from a healthcare facility. I think that's absolutely insane. And what they found was there are a lot of infection control aspects that made proper isolation and infection control measures difficult. So the first is that we have these asymptomatic patients, but it's very common, at least at this time in Korean healthcare, to hospital shop, to go to different hospitals based off of the wait time, the physicians, things like that. They also had 4 patients per room. So if you are in a hospital right now in the US, in most cases you have a private room. We're really moving to that model. But at this time you had 4 patients in a room. So imagine how difficult it is to prevent exposure of an airborne organism in that situation. There was very little access to patient medical information between facilities. So if a patient was transferred, it might not be indicated for a long time that they were, exposed to MERS, or there was a concern for it. You have prolonged emergency stays, and what's really fascinating is that it was an expectation that family and visitors were there a lot and actually partook in patient care. So you have now 4 patients in a room. One of them, let's say, has MERS. Congratulations, all of them now have MERS. But if you have patients and their family is expected, the family or visitors are expected to partake in their hospital care, now we have a whole other avenue of people that are being exposed. So this means that it's not just the patients and the healthcare workers, but also many more visitors that are present for long periods of time and have close contact with their family members, which is going to increase the risk for transmission. So next would be the CRE outbreak. And this one, it doesn't have the glamour of Ebola or SARS or MERS, but I think this is pretty scary. And this is a prime example of those antimicrobial resistance challenges I mentioned. So in 2015, UCLA healthcare system had an outbreak really of carbapenem-resistant enterobacteriaceae, or CRE. We had 8 cases and 3 deaths there. And here's the scary part. CRE is not uncommon. We do see it pretty frequently, but the reason why this outbreak occurred was because of a medical device, and these are called duodenoscopes. And what they found was that it wasn't actually that they weren't being disinfected properly. We were actually doing pretty good with that. It was the fact that the device had poor, really a design, if you will, that allowed for it to be contaminated and not truly sterilized or disinfected. So this is a really good example of not only antimicrobial resistance, but the complexity of healthcare in industrialized countries like the United States, where we have all these really amazing diagnostic and treatment tools, but they can also act as those amplifiers for disease transmission. So there's a lot of other cases out there like this. If you ever kind of want to scare yourself, look up duodenoscope outbreaks, because it's not just actually that we found out that the scopes have a poor design, but the manufacturers are kind of fighting that, and there's no end in, it's just concerning because we're reliant on these devices, and yet there is a risk for disease transmission. So hospitals actually have to go above and beyond now for the high level disinfection to make sure there aren't any more outbreaks like this. So next would be Nipah virus. Nipah virus is a really interesting one that is increasingly becoming a problem because while we are still learning about the disease transmission mechanisms of Nipah, we're seeing more and more that it has a role in healthcare transmission, or that hospitals have a role in its transmission. So in 2001, there was a single patient admitted to a hospital, and they infected 23 healthcare workers and 8 visitors. So we're seeing of the outbreaks that occur, more are showing a propensity for being transmitted in the healthcare setting, both to visitors, but also healthcare workers. So these emergent infectious diseases that we don't see in the US, but that we are seeing trends of healthcare transmission abroad are things that we really need to start looking at, because those are the ones that we should start, having conversations about and developing strategies for. So not to mention healthcare associated infections. I won't be talking about that today, but these are things that we look at constantly in infection control, because here's the truth. If I have healthcare workers that don't wash their hands and I get healthcare associated infections like a urinary tract infection that happens, that should be a red flag that if we're struggling on a just normal day, we are definitely going to struggle in an outbreak situation or something like Ebola where there's a lot of fear involved. So something like influenza is particularly challenging. And I know that seems silly because we can vaccinate against it and healthcare workers should know what to do. But here's the thing, we're increasingly seeing vaccine exemptions, but also that we have really severe flu seasons. Last year, they ran out of Tamiflu. Hospitals really do struggle with flu season because it tests us in the things that we should be doing and we know we're not, like that rapid isolation. I always tell emergency departments, if a patient comes in with a cough, a runny nose, and a fever, ask them to wear a mask. I would rather isolate a patient and take them out of isolation later than find out a day or two later that we needed to really be isolating them. I worked a measles outbreak here in 2015 that was related to Disneyland exposure, and a single healthcare worker who ended up getting it, who worked a 2-hour shift, exposed like 400 people. So those are things that hospitals really struggle with, but are also considered daily infection control, but preparedness issues, because these are the red flags that we should start to see as, hey, if hospitals struggle with flu season or antimicrobial resistance or just basic exposures and outbreaks, how will they handle larger scale threats? So on any given day, 1 in 31 hospitalized patients will have at least one healthcare associated infection, or HAI. I think that's pretty scary, because we should take HAIs as an indicator that we are really struggling with infection control. So hospitals inherently play a very unique role in outbreaks and infections. You've got a sick patient and you've got visitors, and then you've got hundreds of healthcare workers. Is it any surprise that this is a perfect environment for disease transmission? Absolutely not. In New York, the healthcare system that they have, the New York healthcare system has really invested in special pathogens preparedness. And when they went to do drills and, do test patients that came in with SARS, they found that not only did they have some big gaps, but basic infection control, like hand hygiene, was really, really low. 36%, that's really scary. So yes, we can invest in special pathogens preparedness, and we should, but if we're not doing the basic infection prevention practices correctly, there's no way that, we're going to be able to manage those situations. So we kind of need to learn, to crawl before we can walk and then run. So in the event of an outbreak and we have an influx of patients, whether those are the worried well or the sick, it's going to amplify those existing deficiencies we have in healthcare, meaning that an outbreak will inherently get worse because hospitals are those ripe environments. And that means it also is going to really fall on the infection control team. So biodefense, when we talk about biodefense, it's really easy, like I said before, to assume that hospitals, it's an obvious role. It's a given that hospitals have a huge role in biodefense, but really, what does that mean? Because the truth is that when you think about Ebola, it tends to be, do we have enough PPE? Do we have those special pathogens hospitals? But my question is, realistically, can any of us be prepared to handle a biological threat if we're struggling with washing our hands more than 36% of the time? So who's responsible for preparing a hospital? Infectious disease preparedness does fall in infection prevention and control, but we also work to collaborate with emergency preparedness. And that's because, why not have all hands on deck? So you have to ask yourself, you know, who trains healthcare workers and stakeholders, because that's a lot of work to do. And that's realistically, when it comes to biological issues, it's your infection control team that's going to do it. So what are we realistically doing about this big issue? Right now in the United States, we have a lot of awesome biodefense efforts. I'm not going to go through this, but I just wanted to shine some light and, you know, emphasize that we have really invested in biodefense since 2001, especially. There's been about over $60 billion that's been spent on biodefense since the anthrax attacks in 2001. And yet, in the face of all of this, in the face of BioSense and BioWatch and BARDA and the Hospital Preparedness Plan and National Response Framework, a single case of Ebola totally brought the entire US healthcare system to its knees. So keep that in mind, that we're investing in all these efforts, but if we're not getting the basics, the frontline stuff right, we have a big gap ahead of us. So one of these tasks or these initiatives that we're using right now to enhance biopreparedness and biodefense in the United States is the Global Health Security Agenda. And this actually applies abroad. And the whole thing about the GHSA, which is really cool, is that it's saying we recognize, and we learned this in 2014, that we are only as strong as our weakest allies, meaning, so you have a country like the DRC right now that is struggling with Ebola. We should see that as our own vulnerability. So we need to better support countries and help them strengthen their health security, because that's also going to trickle down to us. And they created this whole list of action packages that really focuses on enhancing health security abroad, whether that is biosecurity and biosafety, surveillance, public health and law enforcement, or antimicrobial resistance, which is really cool. And that's actually the one place where you're going to see infection control fall under. That's antimicrobial resistance. So we also created this Ebola treatment hospital designation. And this was in the response, you know, recognizing in 2015 really that hospitals, there was no way we were going to sustain that level of readiness. In the United States, we spent across the board $360 million trying to prepare for Ebola. That's the US healthcare system in general. That's insane. That's a lot of money. So I think we realized nationally that this was not sustainable. It was not going to help anybody. So we created a tiered healthcare approach. It originally started with 3, but now we have 4. So we start with the frontline healthcare facilities. Those are a majority. I mean, upwards of, I think, like 96% of hospitals are frontline healthcare facilities. And this is, all right, you need to be able to hold a patient for 12 to 24 hours, just identify they might be a high risk, and that's it. Next, you have your assessment hospital and then your treatment center. And then there are, you know, in that smaller map with the red circles, those are your special pathogens regional treatment centers. And what this really means is that the expectation is that all frontline facilities should be able to identify, isolate, and inform a patient under investigation for Ebola, then potentially either transfer them to an assessment hospital or a treatment center. So here's the thing, and there's been a lot of debate around the Ebola treatment concept, the design, the healthcare, you know, critical infrastructure layout. To me, and I've unfortunately been present for a patient under, you know, realistic concern for Ebola in a frontline hospital. If I have to transfer them to an assessment hospital and then they get transferred to a treatment center, doesn't that just kind of triple the amount of healthcare workers that we are ensuring get exposed? But also, only the treatment centers get funding. Some of the assessment hospitals get funding, none of the frontline hospitals. So I want you to think about what that means. That means that there is no financial incentive for frontline hospitals to maintain that level of readiness or any level of readiness for Ebola. So we also have the emergency preparedness rule. The Centers for Medicare and Medicaid, or CMS, created this in 2017. And it basically was in response to a lot of things, but also Ebola, saying, all right, we recognize that hospitals are not investing in in emergency preparedness. We're going to make this now a requirement if you want to get your Medicare reimbursement. So they tie this to a financial kind of carrot, if you will, which was really smart. But the problem is, not only are they weakening right now the regulations on this, saying, oh, you don't need to redo stuff every 2 years, you know, do a couple tabletops a year, we'll call it good. But nowhere in here does it say that a hospital actually has to prepare for an infectious disease. It lets the hospital decide what they determine are their hazards and vulnerabilities. So if a hospital says, oh, you know, it's going to be cyber attack, electrical issues, and nowhere on that list is pandemic, flu, or any infectious disease, that's a huge concern. Too many times I have seen bioterrorism on the top 10 and nowhere on there, like Ebola or flu or anything. And when I ask the emergency preparedness people that create it, you know, why is the concern for bioterrorism? There's never really a good answer for that. So I think that there's a huge gap in that we are requiring hospitals to be prepared, but never tying that into infectious disease response. So what does ultimately history show us? Infectious disease threats really evolve from emergent infectious diseases to do-it-yourself biohackers that we now have to worry about, antimicrobial resistance, and that realistically health security is extremely complex. The world of synthetic biology and biotech is moving so fast. There's very little regulatory oversight over this. And yet hospitals are expected to recognize patients that might come in with a lab exposure or be injecting themselves with a genetically engineered organism that they did in their home lab. And we have to understand that, you know, on a good day, Biodefense isn't perfect. It's very challenging. And when we get a surge of funding, that doesn't automatically mean that we have successful efforts. You know, we got a ton of money for biodefense after Amerithrax, and yet here we are still struggling to maintain hospital readiness. There was a recent survey that asked hospital administrators about their Ebola preparedness. And they all said, oh yeah, we're way better than we were in 2014, but a third of them could not tell you where they fell on that hospital tiered approach. And a lot of them said, you know what? We recognize that this is a huge issue, but we just can't support financially putting money into something that we don't view as much of a threat. We're going to buy all this PPE and then it's just going to sit there. So there's a lot of competing interests for us. So hospitals are really amplifiers for disease during outbreaks, but we're underfunding them and really not understanding how infection control, how biopreparedness and healthcare works. So really quickly, hospitals have these infection control programs. I always call us the canary in the coal mine because we're always the ones that are like, this is not normal, pick up the phone and call public health. But the problem is not only do hospitals really see them as cost centers and not revenue generators, but when you look at the literature in biopreparedness and biodefense, virtually none of them ever discuss IPC programs. So many of these checklists and the blue ribbon report and the hospital preparedness plan, they all focus on hospitals as a critical infrastructure and this really big piece in preparing us against biological threats. And yet none of them mention infection prevention programs. They might say, oh, infection control is really important, but what does that mean? That'd be kind of like saying medicine is really important, but never recognizing that doctors have to be there, nurses have to be there. So you're ignoring infection prevention programs and infection preventionists like myself and the role we ultimately had with like Ebola and SARS and MERS is a really big gap, because that says we know that this process is important. We know that isolation and precautions and education are important, but we don't understand who is responsible for dispensing them, who is responsible for ensuring there's competency in them. So while we do see more mention of infection control, unfortunately, that doesn't translate to programs. We're just saying infection control is really, really important, and that's it. So realistically, at a national level, we are recognizing hospitals have these big gaps, but we're still not understanding how to fix them and how we've responded to them in the past. So ultimately, this means that this profit-seeking behavior of hospitals really does weaken biopreparedness, because we're focused on what's either going to make money, but also not wanting to lose money through buying that PPE that we're not going to use. Your IPC programs, your infection prevention programs, are those that are primarily responsible for biopreparedness within hospitals, but we receive minimal support, if any, for that. Hospital administrators have a lot of competing priorities, and guess what? Biopreparedness is not one of them. So it really behooves us from a biodefense perspective to not just understand that hospitals as private entities have competing interests, but that there are programs within hospitals that are uniquely prepared and responsible for responding to infectious disease threats. So that being said, I know I just threw a lot at you, but does anybody have any questions?
Okay, if you have any questions, raise your hand in the chat box and I can call on people.
I'm also always happy to talk about how horrible things were during Ebola or measles and how we're definitely in trouble when it comes to vaccine preventable diseases because people don't like being honest about not vaccinating.
Okay, Jean, go ahead.
Saskia, that was a great presentation. So I'm just kind of wondering about, there's hospitals are, an open door to anybody coming in. Do you see much happening in the future in, some sort of greater biosecurity for people coming in?
Well,
Just because because if you're talking about this as if the hospital is a great amplifier of some pretty nasty stuff, it would seem like, but most of the examples you've given are those that have come in through an emergency room. That's probably a very small percentage of the people that enter into a hospital. So do you see much in the future or need for thinking about the general public and the open door?
Yeah, I think that's definitely something that we're becoming more aware of. Depending on your healthcare facility, upwards of 60% of your admissions are from your emergency department. So it's definitely a majority. But like right now, as we're trying to focus on special pathogens preparedness at my healthcare facilities, and let's say something like Ebola, we focus on travel history, right? Because that's how we pick up on potential high risk patient for an infectious disease that we're not used to. The issue though is, how do I do that for a patient that's coming in for surgery or is being a direct admit from an urgent care or a physician's office? So I think there is a really big gap in how we identify those higher risk patients. But it's also in terms of really having those realistic questions about, all right, so what were you doing abroad? The patient that we had that was a rule out Ebola, it was a really tricky case because he came in and wasn't very symptomatic, and he was an engineer, but and he was a direct admit from his physician's office. So had we not had a nurse who asked, oh, have you traveled? We would have never found out about that. But I think there's a huge gap. If I'm being totally honest, I don't think we're doing a lot to fix that. There are some hospitals that, for example, if you have been hospitalized or treated medically abroad within the last year, they will put you empirically in contact precautions because they're concerned about a very resistant infection you picked up abroad, that medical tourism component. So yeah, I think we really focus on emergency departments, and that's a huge gap. Urgent cares, huge gap. Primary care physicians, another one. And I think that we're just struggling to understand the complexities of healthcare preparedness. So I can guarantee you that we are really not investing in those other avenues.
Yeah, and I was also just thinking about the general public coming in too, coming and visiting people.
Oh yeah, no, we don't do any of that.
Right.
This was actually a conversation during visitor restrictions for influenza season, because I'm sure some of you have seen in hospitals during flu season, a lot of places don't let kids under the age of 12 come in. Well, the question is, are we screening the visitors for sickness? And even if you screen a visitor for sickness, in most cases, it's really hard for me to kick you out of the hospital as a visitor, especially you can't do it if you're a parent and it's a child in the hospital, but we really don't have the resources. It's that simple, because it would fall on the nurse or the volunteer at the front desk. And the volunteer will not have the clinical judgment to make that decision nor feel comfortable doing that. But I can guarantee you a nurse doesn't have the time for it. So we're 100% ignoring the visitors, anybody coming in there who's not being treated.
Right. Yeah. Well, that's what I see every day.
Yeah, it's a big problem, because I can't tell you how many outbreaks we've seen related to visitors and not patients or healthcare workers.
Yeah. So I guess just one comment also about our program here. So as Jen had mentioned, this is a master's degree and certificate in public health preparedness, but there are similar programs in agricultural biosafety as well, biosecurity. So we do have a sister program which offers courses around some of the zoonotic and agricultural based issues that you were talking about that are important.
Oh,
so
yeah.
Folks can take courses in that kind of area as well, particularly talking about animal surveillance, animal infections, zoonotic infections. So that's an opportunity for students.
I think that's great. I mean, it is, and having those conversations too, especially when it comes to a hospital response, is huge. That CJD example, I think, is one that we're really, we have a lot of vulnerabilities for. The communication between medical provider and lab, even, how do we properly disinfect and inform, or do we just toss out the equipment? Those kinds of things. So there's a huge gap in terms of animal health and things like that when it comes to healthcare. So I think that's awesome. You guys are providing that.
Yeah. So do you have a suggestion or a recommendation, or have you thought about having some sort of minimal amount of funding or minimal amount of or minimal percentage of effort that a hospital should devote to infectious control?
Well, that is such a complicated question. Realistically, I think when we try to make it tied to Medicare reimbursement, that's really awesome, but it also needs to be tied actually to private insurance, because we're looking at a private business. I mean, that's realistically how we have to look at healthcare. And if you are going to drive change in a private business, it's 99% of the time, it's not going to be regulatory, because we get around that very easily. It's going to have to be by hitting the checkbook. So I think the best way to drive change in this, by requiring hospitals to not just invest in infection control, but also infectious disease preparedness, would be to tie that to either requiring them to have an insurance, if you will, for infectious disease threats, but also tying it to staffing for infection control, making sure that a number of drills or tabletops are done. There's no requirement for that right now. So a hospital has no incentive to do that, because if you had a patient that walked in with Ebola, I mean, that's that black swan event, that high or low probability, high impact. But what that means is that hospitals are like, well, we'll deal with it when it comes, but it's so financially damaging to them if it happens, and it happens poorly. But because it's so not likely to happen, there's no incentive. So I think if we tie that to a financial penalty, or require them to have that kind of insurance, that would probably be your best bet, because right now there's nothing that exists. There's no requirement that they have an infection prevention team that is staffed appropriately or doing anything related to emergency preparedness.
Mm-hmm. Mm. Okay, interesting. Thank you.
Yeah, thank you. Any other questions? Okay, so I got a question. In terms of the tiered hospital system structure, what are your thoughts and recommendations, training, equipment, and personnel needed for complex interfacility transports? Curious who's driving that discussion. Is it ad hoc, left up to the individual or treatment facility? That's a big one. I really think I think the tiered hospital system was good at the time, but when we focus so heavily on special pathogens hospitals, we're totally ignoring the frontline ones. And we're basically telling them, we're not as concerned about you. We expect you to do this, but we're not going to give you any money for it. So, and it's expensive. I'm looking right now, having about 60 Ebola PPE kits was like $2,000. I mean, it's not a cheap thing. So I really think, again, having that mandated requirement that hospitals have to have a certain level of biological, biopreparedness or infectious disease preparedness is really important, because there's no requirement for that. We're just assuming they're doing it, and they're not. I mean, why would they? They don't, why spend money on that stuff that's just going to sit there? And then the time that it takes to train people, it's extremely time consuming, and maintaining competencies is very costly. So then the personnel needed for complex, and so when it comes to transferring patients like from one facility to another, I know in Arizona, we have a designated plan that was coordinated by the state health department. And without totally throwing them under the bus, it was very worrisome, because the plan was basically, if this patient came into my hospital, the closest assessment hospital, because the two that existed before decided it wasn't financially worth it for them, the closest one is in Tucson, Arizona, which is about 100 miles away. But if this patient was realistically a high concern, the closest treatment hospitals are either LA, Cedars-Sinai, or in Texas. And their plan was to put them into an ambulance and drive them across. They didn't want to do a medevac because it was going to be too costly, and they didn't really know how to decon a helicopter appropriately. So you're talking about driving a patient at least 8 hours in the back of an ambulance. That PPE is hot. Those PAPRs will not last that long. I definitely don't want to be in that ambulance. So when it comes to driving that discussion, it's really state that's driving, or your health departments that are truly driving the conversations about transferring patients, and creating contracts with those ambulance companies that are willing to do it. And I mean, yeah, because the treatment hospitals have to be prepared to receive the patient, but there is no conversation from a frontline hospital about how we're going to transfer a patient. That's kind of, all right, we're going to get help by the designated, ambulance crew that is designed to do it. I know when we were designating special pathogens rooms for Ebola, let's say, in our emergency departments, we specifically looked at how close is it to the ambulance bay, because I really want this to be a quick transfer if we had to move this patient and do it quickly and quietly. So yeah, I mean, I think it's tough because on one hand, the tiered hospital system is a really nice initial first try, but we need to really start revising it. And I'm concerned that we haven't had those conversations yet. So I hope that answers your question. Any other? Yes, we have a huge, huge gap in this. And that being said, the funding is actually set to expire next year. So I know this was a big topic of concern last week when New York healthcare system celebrated 5 years since Ebola and discussed all the hard work they've been doing. But it's also like, hey, that funding is going to expire. And those are only for like treatment hospitals and some assessment facilities. So, recently one of our hospitals reached out to the state health department asking how we could become an assessment hospital, because there are currently none in Phoenix, Arizona. We're a pretty big city. So the response was, well, there's no funding left for assessment hospitals. We can't get you any. So you basically have to front that bill yourself, which is very high. So you can imagine hospitals aren't super thrilled about that concept. Yeah, there's a lot of tough conversations when it comes to the tiered hospital system. But again, it was a good initial response to a really big gap. Any other questions?
I don't see any other hands. If you ever do run into a situation where they don't want to have to worry about deconning a helicopter, there was a very interesting article that I might have written about a capability that the Coast Guard developed called a portable isolation unit that was designed exactly for that purpose, but it is on the GSA schedule.
I'm going to send you an email or call you in case we need to transfer a patient. You guys can just send it our way. Deal?
Yeah. Okay, well, if there are no other last minute questions, which I don't see, I'm just again going to